Where's Patti?
I can't see anyone.
Oh, there she is.
What envelopes there or looking somewhere else good?
That'll be fine. Yeah, and I just go and pick them up. Okay. Is this on? Okay. The Could I have the Family Program Planning Committee along with the Scientific Planning Committee please come to the stage? Hello, everyone. I know a lot of you are still joining us, and we are getting started a teeny bit late. Some things are running a little behind. My name is Stephanie Bozarth. I'm with the National MPS Society, and we are absolutely thrilled to finally be here with you today, together with our team of volunteers and staff. We have pulled together what we know will be an exciting weekend of research and breakthroughs that will all be going towards treating, supporting, and advocating for all our heroes living with MPS and ML. We are grateful for all the creative and innovative minds that have been in collaboration to make this what it is today. Thank you so much. I want to also say a thank you to this planning committee. We have both our science and our family planning committee that have been working on this, which started about approximately 4 years ago in 2014. So I just want to say thank you and give them an applause.
So I'm Patti Dickson. I'm organizing the scientific portion of the meeting along with Dr. Lauren Clark from Vancouver and Brian Bigger from the University of Manchester. We welcome you to this meeting, which for us, those of us in research, is a very special meeting. And this is actually the only meeting that we have that's really dedicated to MPS and ML science, and that we have on a regular basis. But not only that, because we get to interact with you, with the families. And you may not realize what you mean to us, but I'll tell you a little story. And all of us have little stories like this, but I started doing research in MPS in 2003. And when I started, I was a postdoc or a fellow in medical genetics, and like other people, just kind of doing a research gig that I thought might lead to great things. And it wasn't until 2004 where I went to a conference in Dallas. It was a family conference for the Ryan Foundation. And I didn't want to meet anybody. I didn't want to talk to anybody, because if I talked to anybody, they might realize I didn't know anything. You know, they thought I was some kind of expert in this. I was a fellow. I was just starting out. So, but Steve Holland, well, you guys might know Steve Holland, is pretty insistent about certain things. So he was having breakfast with his family, and I passed by them. And he said, "Dr. Dickson." And I was like, oh, crap. Somebody wants me. And he said, "Come sit down and have breakfast with us." And I kind of said, I can't get out of this. And I sat down, and I had breakfast, and they literally pulled me into their lives. And I just never left. And I never looked back from then. You may not realize how much inspiration and meaning you all give to us, and how proud we are when we get to tell people what we do for a living. You know, ask other people what they do for their job, and you hear these answers of people who are investment bankers and make a lot of money, or people who, you know, work at, work at regular jobs, and then you get to tell them what you do. And you know, it's just an incredible gift. So this meeting may or may not change your life. Maybe you're just here for some sunshine, I don't know, a little swim in the pool. But whatever this meeting means to you, I hope that you take advantage of it. And I hope that you have a great time here in San Diego. And please talk to each other, meet each other. Give that opportunity the time it needs to happen. So with that, I'll turn to the second part of what I need to do today, which is present the Life for MPS Award to an incredibly deserving scientist, Mark Haskins. Mark received his veterinary training at University of Pennsylvania, where he also completed a PhD with Don Patterson, who is a founder of the field of veterinary medical genetics. His initial work in the discovery, founding, and characterization of the feline MPS 1 and 6 models grew to a research program involving nearly a dozen lysosomal storage diseases. His work on transplantation, enzyme replacement therapy, gene therapy, and other approaches in MPS disorders has led to new therapies for children. He is a scholar in every sense of the word. His life has been dedicated to preserving, increasing, and transmitting our knowledge about these disorders while helping to improve the lives of patients and their families. He is recognized as one of the most generous and committed collaborators, and that generosity extends to his colleagues. There are few researchers or people anywhere as immediately recognizable as Mark Haskins. When I started in this field in the early 2000s, reading the literature, there were two Marks, and I kept mixing them up. That ended when I met Mark Haskins. He's not just so distinctive because of his most obvious physical characteristic, obviously I'm talking about his eyes, but also because he is one of the kindest, most generous human beings on the planet. Mark is a prince, my lab manager Mary Passage told me before we met, and he has been, always offering to help, collaborate, or just show some hospitality to anyone traveling to Philadelphia. His work isn't always glamorous, but it was necessary. I was fortunate enough to tour his facility where he kept dog and cat animal models of MPS, ML, and other disorders. Mark knew all of those animals, backwards and forwards. He has done so much to advance our understanding of MPS and its treatment. But don't just take my word for it. Here are a few words from some of Mark's colleagues. From Roberto Giuliani, Guilherme Baldo, and team at the Medical Genetics Service Hospital de Clínicas de Porto Alegre, Brazil. Besides being a spectacular human being, Dr. Haskins performed instrumental studies with larger animal models that certainly paved the way to better understanding of benefits and limitations of current and future therapies for many lysosomal storage diseases. In a particular note, he has always been supportive on our initiatives in Brazil, as every time we had an animal with a suspicion of a lysosomal disease in our country, he offered us guidance and help with the diagnosis, for which we are extremely grateful. From Dr. Bigger. There are so many great candidates to put forward for the Life of MPS Award, but Mark really stands at the top for me, with his long beard dangling over the edge. Due to his lifelong interest in finding, developing, understanding, and keeping large animal models of MPS and other lysosomal diseases. Having large animal models of MPS available might seem like an unnecessary expense to some of you, but actually they are a critical part of the process of developing new treatments and help us to understand the pathology of these diseases more effectively than mouse models ever can. No, dogs and cats don't bear a lot of resemblance to humans, but they are much smarter than mice and live a lot longer with disease, thus helping us to understand much more about how this process might happen in patients. They provide a critical safety and efficacy buffer between mice and patient trials and give us an understanding of what might work and what might not. I never had a chance to collaborate with Mark, but I wish I had. I suppose never have enough money to afford his animal charges. But the questions that he was able to address with dogs and cats with MPS have been substantial, always producing interesting papers and of great importance to the field. He is quietly understated but extremely competent, and I counted over 160 published papers to date in some of the top journals, including Science. But there are probably more. These are just some of the reasons why Mark got my vote for this year's award. From Bill Sly, St. Louis University, I could not think of a more deserving person and regret that I cannot be there in person to say so. Mark's zest for good science, collegiality, warmth, and good humor have all greatly enriched my life. His service to the scientific community has also been exemplary. I wish him the best. From Charles Veet, Pennsylvania. Mark is a warm, caring, and dedicated investigator. The people who work with him are loyal to him and appreciate his collaborative skills. From Bob Desnick, Cedars-Sinai, Mount Sinai. Please send my great scientific and political and personal congratulations to Mark. He's a very special person and deserves this award. From Steve Walkley at Einstein. As some of you know, Mark Haskins is sometimes a magician in his spare time, delighting children and adults alike. But I would say that the real magic he has generated over the years is that of turning rare genetic disease discoveries in companion animals into viable research models that have transformed our ability to develop and test therapies against devastating illnesses, including the mucopolysaccharidoses. It is a magic we will miss. From Barb Whittahays, congratulations upon receiving this distinguished and well-deserved award. Your contributions to MPS paved the way for the treatments we have today and for future treatments. Thank you for your dedication maintaining the animal models, a job requiring tremendous perseverance over the years. Thank you, too, for your direct service to the National MPS Society, serving on and chairing the Scientific Advisory Board. It was an honor to work with you over the years, and if you're still hosting your famous parties, I promise my RSVP will be yes. From Steve Holland, to me, Mark Haskins is the physical embodiment of the collective research effort in the modern effort. He, his protégés, his mammal colleagues, and his lab have always been a critical and consistent part of MPS research since we joined the community in 1994. I am always amazed at the many successful research projects he has participated in. But even that is secondary to the love and concern he extends to individuals with MPS and their families. And the top hat, beard, and magic tricks are just icing on the cake. And from his longtime collaborator, Kathy Ponder at Washington University in St. Louis, regarding Mark, as the long-suffering wife and mother of a husband and children who have never been accused of spoiling me, I wanted to say how wonderful it was to work with Mark when any and all requests were fulfilled immediately, or at the very least, once he got back from his biannual trips to France. P.S. Congratulations to the French for the World Cup victory, an event that Mark is likely oblivious to. It was a joy to work with Mark, despite his occasional grumble, and it was not too much trouble to pull out the occasional hair from his beard from specimens. And lastly, from John Wolfe at Penn, who simply says, "Hear, hear." So Mark, hear, hear, a well-deserved Life for MPS award.
You never give a microphone to an academic. I think the most impressive thing, and that went on way too long, is having been a member of the Society for 40 years, the number of people who were at the initial meetings, now of course this was before the internet and people could actually communicate with each other, was a small, small group. And the number of scientists involved in lysosomal storage diseases, let alone MPS, was equally small. And so it is absolutely spectacular to see the number of people who are here, the families and the scientists who continue to come together to try and move things forward. Thank you all very much.
Okay, next we're going to bring up the International Network, which is a lot of the same people, for the International Network, and Terry has a few words to share with us about this network.
Well, for the past decade, a little more than a decade, it became quite apparent that we needed to work on a global and a collaborative level to be able to reach the key stakeholders to help our family and to help the children that suffer from MPS and ML. The International Network for MPS and Related Diseases began their track in which they meet every year to be able to address global issues. And I wanted to take this time to introduce your International MPS Network, because I don't know that all of you recognize that these are people that are global leaders in MPS and ML, and they're from around the world, and they've worked for the past 2 days to try to iron out our next 2 years of very important work for our children. So I'd like to bring them up onto the stage. These last 2 days have been a representation of 19 countries. We've had almost 40 people in attendance. Some of them brought a +1 with them, but that's 19 countries. We have so much work to do. I want you to meet the new co-chairs of the International MPS Network, and that is Bob Stevens and myself, Terry Klein. We're going to co-chair these next few years together.
Some of you may know that last year we lost Christine Lavery and Barbara Wiedehouse retired. They're tough acts to follow. And Terry and I and the rest of the IMPSN are only too aware of what needs to be done and why it needs to be done. The families are the centre of everything we need to achieve and that we will achieve. And we will try our very best for all of you to get the best outcomes. Because at the end of the day, do you know what? We're parents of MPS kids, or siblings, or relatives, and we just want the best for our children too. So we'll work on your behalf and do everything we can.
Thank you.
So our next little section is probably, to me, one of the most important. Living a life with MPS and ML is a rare and unique journey, and I'm constantly inspired by the courage, the perseverance, and the resiliency of this community. It is my honor to serve here, and nothing puts it in better perspective than hearing directly from those that walk this extraordinary path every day. Please join me in welcoming our heroes, and they are going to share a few words with you.
Hi, my name is Annabelle, and I have Morquio syndrome. I may be short in stature, but my dreams are big. I dream of becoming a veterinarian. This is me.
Hi, my name is Jack Todd. I have Hunter syndrome. I am going to be a sophomore in high school, and I'm getting my driver's license in a month and love graphic design. This is me.
Hi, everybody.
Hello, everybody.
Say,
I win.
Say, I'm 8.
I'm 8.
And my birthday
My birthday is June 18.
Yep. And Owen has MPS 3A. And Owen wants to share that his biggest accomplishment last year is that he can write and spell his name. Can you spell your name?
O-W-E-N. Owen Bush.
And can you say, "This is me"?
That's me.
Hi, my name is Jeremy Gatta. I live in Upper Michigan. I have ML3. What I love most is art. I started my own business based on my original paintings. One of my favorite art projects was painting a pink butterfly for Chelsea Bowles, mother of Kami Bowles, who had ML3. This is me.
Hi, I'm Samantha Slauson. I have MPS 1. I have a wicked sense of humor and the innate ability to find humor in the darkest moments. I've been a volunteer for the Make-A-Wish Foundation for 7 years. This fall, I will be attending Colorado University of Denver, studying psychology. My goal is to help children dealing with medical issues to laugh and have a positive outlook. This is me.
Thank you, everyone, for having me today. I wish I could be there with you to speak to you about MPS and what's been going on and the great progress over these last years. When I think back, when I started working on MPS 27 years ago, there were no treatments, and now there are 5 approved enzyme replacement therapies. And that's great reason for celebration. No one thought that it could be done, that these rare and difficult diseases could ever have a treatment, and now we have 5 different ones successfully treated, including the recent one for MPS 7. The MPS 7 therapy gives us great hope that even the rarest of diseases have a chance of getting a treatment developed and getting through the process. But whatever success we've had, ERT is not a panacea. There's many things that are not fixed, and we're not done. Sanfilippo syndrome in particular is needing treatments. There is much work going on, and we're hopeful that something will come from all of it. But the other thing, the bigger picture, is that the rare disease world has really been exploding, and we're really entering the golden age of rare disease therapeutics with all kinds of therapeutic modes, gene therapy, mRNAs, exon skipping, and other types of strategies that are out there changing the future for rare disease therapies and for rare disease patients. And those offer new opportunities for MPS patients to get even better therapy or to get their very first therapy. The challenges still remain in getting those therapies to patients. First, getting the development is still a large problem, particularly in diseases that are highly variable or affect the brain, where measurements and really being precise in knowing what the answers are is just not possible. With those challenges, we have to do more in this 21st century ecosystem of patient, the healthcare provider, the researchers, and the development companies, as well as the regulators, on trying to develop ways and approaches to solve these difficult problems so that more patients can get treated. And we need more patients involved in the clinical development process. I think one of the most important things is for patients to participate in survey studies. These are clinical survey studies where we measure the disease and really understand it deeply. We all talk a lot about natural history, and natural history is important. It's also expensive and takes a lot of time. But really good survey studies, I would highly recommend, is something patients should participate in, and we need to learn the breadth and range of variation in patients with rare diseases like MPS, and we need to understand how to measure them as best we can. When we do this, we'll learn one thing I have learned from the beginning in all these 27 years, that MPS patients are highly variable, and that is making things very difficult. In our clinical trials with the larger MPS, we could restrict to certain patients for the trials. But what do you do when you can't restrict, when the disease is too small, when you need to treat everyone? Or what do you do when there's patients who have more advanced disease and less advanced disease? If we just select only those patients at a certain stage or a certain type, we're not really treating the population, and we're cutting out a lot of patients from opportunities to participate in that research. So we need to develop methods to manage the heterogeneity, the variation between people, and do studies that involve more patients. Survey studies help us understand that variation and help us develop those endpoints. But we then need to work with regulators and developers on developing multi-domain endpoints, endpoints that capture more than just one thing, more than just walking or breathing, but a lot of other aspects of their disease. And that's particularly important in brain disease, which have been so hard to treat and hard to develop therapies for. We also need to develop all-inclusive type studies that will allow us to see all the patients in a study. If we have multi-domain endpoints that can measure different people on different things in the same study, that should allow us to include studies that enroll everyone. If we can enroll everyone and measure them all, then we have a chance at actually understanding how to treat all the patients with the disease and not just those few that we've designed the study for. I think these are things that need to change and things that can be improved, and that the participation of patients, developers, and the regulatory authorities in allowing and developing such methods. We did use these methods in the enzyme replacement therapy program for MPS 7. Those methods allowed us to do a 12-patient study, all-comer, and to evaluate for clinical efficacy. It was successful, and I think it's a method and approach that needs to be adopted for more MPS therapies and more of these therapies using all these new methodologies. So thank you once again for giving me the opportunity to speak to you about the 21st century ecosystem and all the work we need to do together, and about how to improve the development process regarding measuring disease in MPS patients. I appreciate this opportunity, and I do wish you a great meeting. Thank you for having me.
Hi, I would like to welcome Melissa Bilodeau to come to the stage. She is one of our keynote speakers. She has MPS IVA and also a board member of the Canadian MPS Society. This year is especially a treat that we have two keynote speakers that are directly from our population and sharing their experiences.
Hello. I just wanted to say, first of all, I'm a bit nervous about this particular presentation because it's not my usual go-to. I've never seen myself as somebody that's special or done anything special. I've just lived my life, and I've just gone through it, and that's pretty much what I've taken out of it. They told me to do something inspirational, and I really hate inspirational books, so that's how close we're gonna get. So how do I switch the... Yeah, thank you. So I just wanted to give you a bit of background, but I'm not gonna go into my medical past. Everybody's gone through surgeries. So at first my mom noticed I had this small bump on my back. And but the doctor said not to worry. It was like it was normal stuff and nothing special. So she had another kid, my brother, and at 4 we were both diagnosed with MPS IVA after a few years of processing. And I was doing ballet by that point, and I stopped because it got too painful. I got my wheelchair in 2nd grade, and then I started having surgeries, and so did my social involvement begin. I was very prompted by my mother to not stay in my personal bubble, but really be outgoing. So I wanted to address something that is very recurring, is like normal, being a normal person in society. And if we look at this room, honestly, being somebody with MPS is normal. It is the norm. Most people have it. It just, I feel it's because of your context, and I don't see myself as somebody that's particularly courageous or abnormal or whatever. I'm just me. And there's an important difference, I feel, between perceiving that you're different as a child. You notice that, of course, having surgeries might not be normal, but I thought it was normal. I thought everybody had surgeries all the time, and I mean, for me, it was nothing special. When somebody told me I was courageous, I was just wondering what they were talking about. And so my mother never taught me I was different. She raised me as any other kid would be raised. And I think that had a very important impact on my life and how I perceive myself in the world. And so I feel like the way people react towards you in a social situation will not impact me as much because I don't see myself as particularly different. And I feel like how you learn your disability and how you're not taught it will have an impact on time. Can we? Thanks. So it's just a quick quote about how I see myself in life. I think that above all, you should consider yourself, you know, like the player in your life. I'm not a victim. I'm a player. I'm a fighter, and you know, I'm not gonna step down and just take it. Like if I want something in life, I'm just gonna go and get it and fight for it. I mean, that's pretty much it. And so this difference that is often perceived by other people when they treat you, you know, it might be like when I'm doing my grocery shopping, they might, you know, act in a certain way. I just don't really see them. But I've started to see it when I got into university as a particular opportunity. Often people would think about disability as a weakness. You know, you can't do certain things, of course. I can't run. I can't climb a mountain. I don't really want to. It's okay. And when I go into different social environments, for example, university, my experience give me a strength on other people because they're a vision on life that I have and a capacity to connect with people in other difficult situations in the world. I am very lucky that I was born in a country where you have healthcare, where you have doctors that are very competent and researchers and, you know, like a good living. And not everybody in the world has the same, you know, same chance as I did growing up. And so my whole process has led me to want to defend other people in different social spheres. And so the way I see it, my disability can lead me to help people get greater social justice and understand people in a various situation, not just disability. So for me, it's really an opportunity to, you know, raise awareness in the world. So that's pretty much it. Thanks. And so right now I'm currently studying political science, which might seem a bit ew for everybody, but really political science is about, you know, finding where the power is and getting some power. And, you know, when you get some power, you can change some things and help some people that might not have a chance to do that. Not everybody in the world has the same chance to, you know, like some children are more affected, for example, and not everybody has the time. Some of you are very, you have your hands full. It's very difficult. So I feel that I have the chance to give back to society the way I've been given an opportunity. And I would say that it's not a perfect formula how I see the world and how I see my life. It's really, you evolve as you grow older. But I would always stress that it's important to take the time in life to enjoy the successes. And the successes aren't necessarily like getting into university or, I don't know, like finding treatment. I spent most of my life without treatment, and I would say that the smaller successes are what makes it. You know, like that time where I make it up the hill with my latte and my laptop and nothing breaks. I mean, that's pretty successful. But I mean, I speak with some of my friends and who have brothers with, you know, a higher disability, and you know, going grocery shopping with your sick child who doesn't make any fuss for like the whole time, that's a success. I mean, everything is a success, and you have to take the time to see it. It's not just, I know a lot of people in this room might not have access to treatment, and I lived most of my life without treatment, and that didn't stop me from seeing some successes and, you know, keeping in touch and hoping for more. So that's pretty much it.
Okay, our next speaker is Carolina Hartmann from Switzerland, and she is also with the she is 20 years old, and if she wants to come on up.
Hi everyone, I'm Carolina, and I just want to start off saying I'm not from Switzerland, I'm from Brazil. I don't know what happened here, but anyway. So, my name's Carolina, I'm 20 years old, and I was gonna say now this part that I'm from Brazil, but okay. I'm Brazilian, I grew up in a really small town, which literally translates as don't touch me. In English. In Portuguese, it's no me toque, so it's kind of weird. And I have a really small family. I have a 16-year-old sister. And my mom's an English teacher. My dad owns a store. It was a really regular life. Before you said almost everything I wanted to say. It's not, I don't know what to say. I don't know what, like, they told me, give an inspirational speak. I don't know, because I just grew up. I had a really normal life. My disabilities and my little pains and stuff, they never stopped me from doing anything, because I never knew a different life. And nowadays, I live in a city nearby, an hour away drive. And I go to med school over there, and I live by myself, just me and my dog. And I want to take this opportunity to thank Dr. Carolina. She's my geneticist, and she was, I can say, one of the biggest inspirations for me for going into med school. I always wanted it, but I grew up surrounded by amazing doctors such as herself, amazing people, terrific doctors, and they made me see a light. They made me see my future as bright as it could be. And so I went into med school to try and help more people like me. I have a very mild case of MPS, a very mild presentation, and it was really hard to be diagnosed, clinically diagnosed. And she worked really hard, and now I have the diagnosis. And yeah, that's basically it. I just live my life as normal as it could be. I'm surrounded by amazing people. My mom, my dad, my sister, my whole family, they always treated me like a normal person, because I am a normal person, like she said before. Here, the normal is having MPS. And my friends were always great with me also. They always treated me. I can't run because I have some hip issues. I have some pain. We'll not run. Nobody will run. We'll stay here with you. We'll watch a movie. We'll do anything that you can do. So I was surrounded by very special people my whole life, and that made me feel like me. And I also want to take this opportunity to thank all of you researchers and doctors and parents who give your life without expecting anything in return for us, for MPS and ML patients. You don't know how important that is. You don't know how great that is, what a gift that is. So I want to take this opportunity and say from the bottom of my heart, thank you.
So at this point, I want to say a thank you to our keynote speakers that were both on video and in person to launch the 14th International Symposium on MPS and Related Diseases. I also want to say a deep thank you to our very gracious sponsors that have supported us at so many different levels. Without their contribution and partnership, this symposium just simply would not exist at this global level. From the patient voices to the expert and innovator, we can all make history together and change the future of these diseases. So we are now going to be moving into the next part of our program. So I will invite you to proceed to the exhibit hall to see everything that is up right now. We will commence with the scientific and the family program tracks at 5:30. Excuse me. What? Oh, my heavenly days. That was not on my list. Now I will invite Brian Bigger to the floor. And everything I just said, just think about it later.
So I'd just like to invite everyone to proceed to the exhibition hall. That's worth a try. Yes, thank you very much. So I was asked to give an inspirational speech. I mean, seriously, what a tough series of acts to follow. So I feel pretty humbled after all of those speeches, and this is going to be a little bit different, I think. So bear with me, and hopefully it'll be okay. So when I was researching this, I thought, well, how do I come up with, a vision for the future? What is the future of therapies today? And of course, I turned to the internet, and I thought, well, maybe Ridley Scott can help me out with his vision of the future. Can we maybe move off this screen here and move on to the full slideshow presentation on all 4 screens, please? I think everyone's read enough about me already. So this is 2019, believe it or not. This is Los Angeles in 2019, Blade Runner. And originally it was a Philip K. Dick novel, Do Androids Dream of Electric Sheep, written in 1968, I think. And this was his vision of the future. It was a bit different to how it is now. So his vision included androids running loose on the streets, a strange investigator here, the Blade Runner. And it also included some really bad weather as well. So I don't know what had happened to Los Angeles, because it's not really like that now, is it? But interestingly, they also had some medical devices on here, and one of these was a behavioral test that the Blade Runner had to do to sort of prove that he wasn't an android. And I think all this proves is that they've just managed to get rid of the neuropsychologist in the behavioral test. But you can see that it just looks like the basic eye test, really. It doesn't really change much. So this wasn't much help to me. So I thought maybe I need to go further forward. What about the 23rd century? Maybe there's something there. So I went to Star Trek. Same bedside manner. Great, we've got a doctor. You'll notice that they're actually repairing DNA in this particular screenshot here. So, things have moved on. And maybe we'd be able to do repair of DNA ourselves. And I thought, well, maybe there are some other examples as well. And of course, we've also got 2001: A Space Odyssey, which is really interesting because they seem to spend a lot of time putting people to sleep in these strange contraptions. And they also had a real problem with voice recognition. So, you know, nowadays we have this problem with sort of Siri and Contessa, whatever she's called. Your Cortana, that's the one, your Microsoft assistant. Well, they had Hal, and Hal just said in a monotone, "I'm sorry, Dave, I'm afraid I can't do that." So, yeah, I'm hoping things will actually move forward a little bit better than that, and perhaps more effectively. So I thought, well, okay, we're going to have to go back to basics. So what do we really know about MPS in the 21st century? And what can we take forward from this knowledge that we can use in the future? So what do we know? We know that MPS diseases are mainly multisystem in nature. We know that all of them are caused by a genetic lack of lysosomal enzymes with a buildup of undegraded GAGs and other products in cells. We know that all cells are affected biochemically. But actually, when it comes down to it, some organs are affected more than others, and some organs don't seem to be affected at all. And the age at onset can be variable, hugely variable. So what's going on here? Why is it so different? We also know that replacing enzyme in cells can correct disease. We know that enzymes, most enzymes, can move between cells, but they might not do so very effectively, and they might do so less effectively than we originally thought. We also know that correcting other aspects of pathology, so the other storage products, other manifestations of disease, behavioral issues, cognitive issues, could be worth pursuing. But what is important, and what should we be focusing on? We also know that from several different treatments that the earlier the treatment, the better the outcome. And that's pretty fundamental in this area. And the final question really is it ever possible to cure? So to give you a little bit of background, enzyme cross-correction in MPS, we know that lysosomal enzymes are made in cells. Fair enough. They're tagged with this little biochemical tag called mannose-6-phosphate. And all that does is it has a little address label that says, send this enzyme to the lysosome. The lysosome is a compartment within the cell which allows these long-chain sugars, these GAGs, to be broken down. It also does several other things as well, but in terms of MPS, this is perhaps the most important fact. But interestingly, in that process, it's not a perfect process, and often some enzyme is secreted out of cells as well, so that means it leaves the cells, and it floats around outside. And other cells, such as this one over here, have these mannose-6-phosphate receptors on them which recognize this address code, this tag, and they can take those enzymes up. And that is the principle by which cross-correction happens. So this is the basis for enzyme replacement therapy. And essentially what this means is that if you deliver the enzyme in the blood, it can be taken up by most cells of the body. There are one or two exceptions to this, and in MPS IIIC is perhaps the biggest exception in MPS disease, where the enzyme can't move between cells. It's membrane bound, so it's bound to the inside wall of the lysosome. So what do we have at the moment in terms of treatment? Well, we've got enzyme replacement therapy available for all MPS with somatic disease, as Emil said, but none that are primarily neurological. And that's not to say that we don't have enzyme replacement therapies for MPS 1, 2, and 7. We do, of course. But how effective are they at actually treating neurological symptoms? And we know that replacing enzyme is an effective treatment, at least where the brain isn't involved. It's not perfect, but no treatment is. And so if we have a look at what treatments we have, you can see that there is a resounding gap in the middle here, which basically encompasses Sanfilippo disease. You'll also notice that some of these treatments are maybe less effective in where there's a lot of neurological, where there's a lot of brain involvement as well. So in MPS 2, about 2/3 of patients will have brain involvement. And in MPS 1 Hurler, for example, actually bone marrow transplant is the preferred method of treatment. And in MPS 7, I'm sure we'll have further developments coming soon. So I think we need to be realistic about the limits of every therapy. And being realistic about the limits of every therapy means that we can develop new ones, because we can work out what's not perfect about this therapy. Every therapy is an advance, don't get me wrong on this, but we have to be realistic about where they can take us to and where we need to go next with them. And when we target other aspects of disease, it's important we understand what that aspect of disease actually does, if anything. So what do these undegraded substrates do in the body? Is it the GAG that's responsible for disease? Is it the GM ganglioside that builds up? Is it cholesterol? Is it something else that we're not getting? Or is it a mixture of everything? Well, we don't really know, actually, if I'm honest. So if we look at disease pathology, some of the things we do know, we know that we have a missing lysosomal enzyme, and we know that all MPS diseases have this. Great. We know that they all accumulate GAGs, but they're all a little bit different. So each GAG is slightly different. Some are heparan sulfate, some are dermatan sulfate. And even within each subdelineation, if you like, so heparan sulfate has got lots of different subtypes as well. It's not all the same thing. We also know that if you have heparan sulfate accumulation, primarily you'll tend to have more brain disease. And dermatan sulfate and keratin sulfate, you'll tend to have more bone, joint, and cardiac disease and heart disease. But it's not a set thing at all. We don't really know what's happening with lysosome dysfunction or cholesterol. These are other things that are going on in the body. And we don't really know what's going on with these GM gangliosides, these other storage molecules. All we know are that these are things that we measure that are problems in other diseases. So things like GM gangliosides, tau, some of these are implicated in other lysosomal diseases or in Parkinson's or Alzheimer's, for example. And we also know that inflammation is important, but we don't really know how inflammation is important. And we don't really know how to deal with it or whether dealing with it will make a very big difference. So these are some of the things that I'm going to try and address today. So for me, it's all about location, 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 as it ever is, right? So each therapy is really only as good as its distribution system. Regardless of what treatment you deliver, the mode and the effectiveness of delivery is absolutely critical to how that treatment is actually delivered and is effective in a patient. We've got about 10 trillion targets in our body, each of us. That's quite a lot. It's what, 3 times the US national debt? That's maybe a bit more by now. But it's a lot, right? How do we hit them all? Do we need to hit them all? Are there certain bits we need to go at and other bits we don't? If we have drugs and enzymes that can target all sites in the body, despite the blood-brain barrier, then actually we're getting part of the way towards this. And so directing delivery to specific organs using things like tags, directed delivery, or improved devices are all actually important steps forward for this disease, for these diseases. We also need therapies that can replicate within cells and move between them. So that means that when a cell turns over, it continues to produce enzyme or it continues to produce the therapy. So these kind of therapies can be gene therapies, genome editing, or stem cell gene therapy, replacing stem cells and making new cells. Can we achieve a sustained normal function of cells with a therapy, or is that impossible? And can we replace cells with new ones? So these are all things I think I'd like you to ponder, but not too long. So how do we measure an outcome in a patient? And that's perhaps the last and most difficult thing that we have to address. So what kind of modifications to enzyme replacement therapy are out there? Well, there are quite a few novel enzyme replacement therapies out there aiming to circumvent these barriers. Many of these are in preclinical, some are in clinical development at the moment. They're all getting there in some form or another, but we still need a lot of trials to take these forward. So one approach is just to go in with intravenous enzyme replacement therapy, and we've heard about some of these approaches. So just straight into the bloodstream. The other is to think about bypassing the blood-brain barrier by a physical injection or intervention. So that would be some of the intrathecal approaches, going in with a lumbar port in the spine, or the other approach is to actually have a catheter coming into the ICV, into the ventricular space in the brain. So these are just the spaces in the brain with a reservoir back down in the body. And these are all approaches which are being tried at the moment. In some cases, overproducing the drug or overproducing the enzyme might improve delivery. So we know that if you can extend the circulation time, the length of time that the enzyme remains active in the body, then that can improve things. And we can also think about how we can modify enzymes to improve their uptake. So there were talks this morning from the BioMarin group about the GILT tag system, which is a fusion of the enzyme to IGF-2, which is a tag which basically just permits greater uptake through mannose-6-phosphate receptors. So it binds more effectively to cells and results in better uptake of enzymes. You can also do this through insulin receptor antibodies, modifying the carbohydrate structure, so the sugar structure on the surface of the enzyme. Or you can think about fusion proteins to peptides which would normally cross the blood-brain barrier. So we have an active transport system of proteins across the blood-brain barrier. We also need to think about whether there are issues with delivery of enzyme in terms of producing antibody responses. So you can get two kinds of responses to an enzyme delivery. One is an infusion type response where you might have a reaction, initial reaction to an enzyme. But the other is a long-standing response where you might have antibodies produced over a period of time, which might then limit the efficacy of the product. Now, we know that in most cases this isn't actually much of an issue, but we have seen some issues with inhibitory antibodies, particularly in MPS I. And so I think that tolerization regimens to try and limit that antibody response are going to be an important factor, actually, in future therapies. And really to try and just improve how effective enzyme replacement therapy actually is. So bone marrow transplant is already around. On the plus side, it's a really good way of delivering a lot of enzyme from blood cells. So if you do a bone marrow transplant, you are basically replacing your entire blood system with a new one. And all of those cells are able to produce enzyme. So that's a pretty neat trick in terms of scale-up. You'll get about a couple of trillion targets that way. But are they the right targets? Well, that's something we don't know. So it's extremely effective in MPS I hurler and does have an effect on the brain as well. And the reason for this is that some of these cells from the bone marrow traffic past the blood-brain barrier and they engraft in the brain where they can release enzyme at that point. So the downside of that, of course, is that at the moment we're having to treat very early for an effect. And part of this is because it requires chemotherapy in order to get an engraftment to work. And so it's not a perfect treatment at all. And there's also limited correction of bones and joints, much like enzyme as well, in fact. So how can we improve on this kind of therapy? Well, one way of doing this is stem cell gene therapy, which is to use a gene therapy vector to overexpress the missing gene, the missing enzyme, in the patient's own blood cells. So the idea would be you'd take cells out of a patient, you would transduce them with the gene therapy vector, put them back in, they would engraft, and you would have a correction of disease. And as you can see here, some of these monocytes will traffic to the brain and release enzyme beyond the blood-brain barrier. The big advantage here is that you're able to overproduce enzyme, which means that it will be pushed out of the cells more effectively so that you've got more circulating in the bloodstream and more circulating in the brain. It also means that you have your own blood cells, which means that you have a limited immune response. So it's much easier to engraft these cells than to engraft cells from somebody else. And it will result in a permanent correction, assuming that you get full bone marrow chimerism. However, and it has the potential to be transformative. So we've seen in metachromatic leukodystrophy, which is a similar lysosomal storage disease affecting the brain, but primarily with motor dysfunction, so problems with movement. And this is the gross motor function of patients here on the left. So this is their ability to move their arms and legs, walk, and so on. You'll see that these patients in gray have not been treated. These patients here have all been treated, and with one or two exceptions, that exception there is somebody who didn't engraft successfully. These patients are generally walking and in some cases running, and it's really been a truly transformative treatment in those patients. So this is a trial in Milan that's been running for many years now. On the downside, it's an early treatment window. So these patients had to be treated very, very early in life, and we don't know how far you'd be able to push that treatment window. It still requires chemotherapy, so there is still a mortality risk, although it's obviously lower than a normal bone marrow transplant. So we've done something similar to this in MPS 3. So we've taken the same approach that they used in Milan. We've made so this is a gene therapy vector here on the top. The SGSH is the enzyme that's missing from MPS 3A mice in this case, and also from people with MPS 3A. And what we've done is that we've put what's called a promoter in front of it, which drives the gene expression. And this one, CD11B, happens to drive gene expression in monocytes, these cells which traffic into the brain and engraft them. So we tried to make it more specific for the brain than the original vector that they used in Milan, which had this PGK promoter. So we basically took stem cells from MPS 3A mice, we transduced them with the vector, put them back into mice after transplanting them, and we looked at outcomes. These cells traffic to the brain. You can see about 20 or 30% of them engraft. These are the green things you're looking at. And they're rather pretty cells. They're nicely spread out in the brain like this. And you can see also that we get huge levels in the periphery, way higher than normal levels. So in the bone marrow, we get about 5 times normal levels. And in the brain, we're getting about 11% with the CD11B promoter. And what kind of correction does this give? Well, these mice are hyperactive as well. So MPS 3A mice really like running around quite a lot. And you can see that after treatment with the CD11B vector, they're completely corrected of their hyperactivity. So we've now done this study several times with several different diseases. So this is just a little bit more data from the MPS 3A just to show you the brain correction. This green stuff is the lysosomal material. The red staining are neurons. So these are your brain cells up here. And the green stuff in the MPS 3A is the lysosomal storage. Okay? So you can see that you're able to correct that very effectively with CD11B. And inflammation here, which is the brown staining, so these are brown cells, you're able to also correct that in the brain, in mice, I might add. So we've done something very similar with Becky Holly's work in MPS 3B, replacing the NAGLU gene. Same kind of study, again able to correct behavior in the mice, and again able to overproduce enzyme. And we get about 13% of normal levels in the brain, which seems to be sufficient to correct the behavior, at least in the mice. We're also able to completely correct the amount of heparan sulfate present in the brain in all cases. The other thing that we've done in MPS 2 is a similar kind of approach in MPS 2, but we took it another step further, and we wanted to try one of these tagging peptides. So if you recall, I told you that you could use these peptides to cross the blood-brain barrier. Well, that's what we put on here. And we did the same kind of experiment again. You can see here that we get a very good level of engraftment in these mice. So they're fully chimerized with donor cells. And you can also see here, before treatment, this is a normal animal here on the left. This is an MPS 2 animal in the middle. These are its brain cells in green, and the lysosomal material is in red. And you can see that we get a complete correction with the ApoE2 tag. So this is designed to cross the blood-brain barrier. In fact, it didn't quite do what we expected because it doesn't just cross the blood-brain barrier. It actually also improves uptake into cells as well. So it was kind of a double whammy, actually. And when we look at the behavior in these animals, we find some interesting things. So if you look on the right-hand side, this rotarod test is basically the mice have there's a rotating drum, and the mice have to run on the drum, okay? And this measures essentially measures their physical activity. And the all of the treatments that we delivered, including a normal bone marrow transplant, were relatively effective actually at correcting some of the physical aspects of disease in a mouse model. Mice aren't quite the same as humans, so we do get some correction with a bone marrow transplant, which you might not necessarily expect to see as much correction in patients. But when we look at this other test, which is called the Y-maze, and this is looking at working memory. So this is a decision-based test. The mice have to go into one of these different arms. They either go A, B, C, or whatever. They make their own choice. If we put a human in this test, generally you will make a decision that you will go to each arm in turn, and you will explore each arm in turn. And the mice do the same kind of thing. And so what we're looking at here is the ability of the mice to make the same decision and to differentiate between the different arms. So if they continue to make A, B, A, B, A, B, A, B, it kind of means that they've forgotten about arm C. So it gives you an indication of how good their working memory is. How can they remember stuff that they've just done? And ApoE2 was the only treatment really to fully correct that aspect of disease. So we think that this is more brain specific in this case because it's able to correct this aspect of disease rather than just the physical movement, if you like. And so some of these treatments have been taken forwards. We developed, we made a GMP vector for this, so we have to produce a vector for clinical trial. The idea would be that these cells would be frozen, transduced and then frozen, so it would make it safer for patients. And basically, some of these therapies have gone to Orchard Therapeutics, who are developing MPS IIIA and IIIB. And there's some talks later on in the session which will talk about this preclinical work in MPS IIIA, which I won't bore you with now. So what about AAV-mediated gene therapy? This is another thing you've all heard about. And generally what we're trying to do here is the direct injection of an AAV gene therapy vector to overexpress a missing gene. So it's the same kind of principle, but rather than going into stem cells, we're trying to put this straight into a patient. So if we go in intravenously into a vein, we know that AAV9 can cross the blood-brain barrier, and although many AAVs are eliminated by the immune system, you can still get to the brain if you give high doses. And this is the approach used by Abeona. A brain-targeted method might be to deliver directly into the brain, and you can either go into the brain itself, or you can go into the spaces in the brain, intraventricular. And typically we'd use things like serotype 9 and 10, and these are just the coats that surround the AAV itself. On the plus side, in targeted cells, you get very high gene expression with long-term correction. And it also has the potential to be transformative. You know, these treatments should be transformative. They are transformative in mice. On the downside, it can be difficult to distribute the vector widely. And it's not a problem so much of moving it around the whole system. It's a problem of having too much in one place and not enough in another. And this can lead to scale-up problems, both for intravenous, where you have to give very high doses, or for the brain, where typically you tend to be a little bit limited by the amount of volume that you can deliver in the brain, because too much volume leads to swelling, and swelling in the brain is bad. You can also have immune reactions to AAV, and these sometimes require immune suppression as well. And one issue that's really become, I think, more and more obvious with AAV is that many patients can have pre-existing antibodies. So this means stratification of patients down to a smaller subgroup again. So one way in which you can address this, and there are many people working on this aspect of disease, and there are many people working on different ways of addressing distribution. But one way that you can look at this is just, you know, here we've got an injection site in a mouse brain. The mouse brain's tiny, it's about that big. Spot that? Yeah, okay. And so the injection site is, you know, it's pretty small, doesn't give a lot of distribution. So we've been working with the team to try and improve the distribution, not just using different types of AAV, but also using different distribution systems as well. And we've recently published some work, basically where a group from King's College in London developed this novel coat protein called TrueType, and you can see that it just gives much better distribution throughout the brain. And the trick here was interesting. It was actually detargeting the vector. So AAV9 is really sticky. It's a very, very effective vector. It goes into cells really effectively. But the problem was that it was a bit too effective, so it just didn't move beyond the site where you injected it. So just by detargeting it and making it a bit less sticky, you're actually able to get across a wider distribution. And we tried this in the MPS IIIC mouse model. And you've got to remember, MPS IIIC is non-cross-correctable. So you're trying to hit as many cells as you possibly can in the brain. And that's a tough call with AAV. So what we found after giving 2 injections in the brain in mice with MPS IIIC, we get a lot of enzyme around the injection site, which is here in R2, and less enzyme in other places, not so much at the back of the brain at all. However, we are actually able to correct both the hyperactivity and the working memory, the Y maze, if you remember, in these mice, despite the fact that we've only reduced heparan sulfate by about half. So we're thinking that this might be a viable approach. But another aspect that we need to think about is how do we actually improve that distribution within the brain? What can we do physically to improve that? So Albiona have one approach to this, which is to deliver intravenously. It's quite a costly approach in terms of amount of vector used, but it does appear to be giving at least a biochemical effect in the brain, and quite an impressive biochemical effect in the brain. If we look at an interparenchymal system, where you're delivering directly into the brain itself, these have been less effective. And although we've seen some stabilization of disease and some reports of neurological improvement, these have been relatively mild, and the biochemical improvement has also been relatively mild as well. Not quite the step change that we were really hoping for. So what's going on? And we think that it's just about the volume of delivery to the brain. So can we increase the volume of delivery to the brain? Can we try and work on the way in which we deliver to the brain? And the approach that we've been working on is called convection-enhanced delivery, and there are actually several groups working on this. We're doing it in sheep. This is the kind of image-guided system that you would use in kids. In fact, it's from the Children's Hospital. And here's a sheep. And this is, in fact, brain delivery of AAV into the sheep. So we hope that we'll have something interesting to report. The sheep is quite a nice model because it's about the same size as a monkey. So the brain is about 1/10 of the size of a human brain, and it's about as big as you can get in a large animal model. So what about gene repair? You've probably heard a lot about gene repair. And there's been quite a lot of excited press about it. What is it? What does it do? So we've got 3 different ways of doing gene repair. Basically, we've got zinc finger nucleases, ZFNs, talons, or CRISPR-Cas9. And they all work on the same principle. They introduce a double-stranded break in DNA, so they basically break the DNA in half. And then using different kinds of proteins, they allow either a repair of that, so they just repair the ends together again, which usually introduces a mutation, or you can use a guide which allows you to repair an area that's been changed. And this would allow you to potentially repair disease-causing mutations in MPS. And that's just a picture of CRISPR-Cas9 for you. But basically, it does it in exactly the same way. It just uses the RNA as a guide and template instead of a protein. And there are some approaches out there at the moment. Sangamo has got approaches in MPS I and MPS II, both of which are interesting. But unfortunately, the technology at the moment relies totally on AAV. And so the delivery system is an AAV-based delivery system for all of these approaches, which still relies on the delivery problem again. So it all comes down again to how can you deliver best to cells. And so I think it's critical that delivery is addressed. What about the other therapies, chaperones, stop codon read-through, and substrate reduction therapy, and so on? Well, the chaperone and stop codon read-through approaches, These are ways of trying to boost enzyme expression by allowing them to refold themselves properly. They can allow for improved enzyme activity, and thus they can target the primary problem. It's important that you have drugs that can cross the blood-brain barrier, and you're not going to have antibody responses to these, of course. It's also cheaper than ERT. But on the downside, you can often have significant side effects. They're usually limited to patients with specific mutations in MPS subtypes, so you can end up with a very stratified population. And they tend to offer marginal improvements in activity, at least so far, and I'm hoping that they're going to improve, actually. So they also have lower efficacy than ERT, and I think this means that it's critical that they target the brain or the bones, because these are the areas that are the least well corrected in the MPSs. Substrate reduction therapy is actually targeting the product that builds up. So in this case, we can target the production of glycosaminoglycans in the cell. So the cell naturally produces GAGs to be used inside and outside the cell, and it's only when they come back in to be broken down that everything goes pear-shaped, basically. So if we could target the normal production of these substrates, then perhaps we can do something about it, assuming that we're targeting the right substrate, of course, and that that substrate actually does something in the body. So we know that it can work. Miglustat Zaveska is a product used in Gaucher disease, and this works on this principle. And there is potential to treat the brain. So on the downside, they will have a moderate effect. Eventually, abnormal GAG is going to build up, and disease is going to progress. And you're not really treating the fundamental problem in these diseases. And because we have a limited understanding of mechanism, it means that the drugs are going to be less effective. So what about targeting something else? So more specific treatments mean fewer patients targeted, but a greater effect size. So ERT, gene replacement, gene editing, great. If you can distribute it properly, then you can have a really large effect on disease. Chaperone and stop codon means further stratification, smaller effect size, but still potentially pretty good. But the broader treatments are interesting because you can target more patients. You could target across a number of different diseases. So they're, beloved of pharmaceutical companies. But they generally have a lower effect size. So the real issue is that they're not targeting the main cause of the disease. They'll tend to be delaying disease progression. However, if you can prove that they work, then they'll be really useful adjuncts for specific issues in patients, and especially where patients are not eligible for other trials. And this is going to become an increasing problem in the field, where there'll be patients who will not be eligible for any trial, particularly for gene therapy trials. And so I think it's really important that we have some of these other treatments available for patients to be enrolled on. So I'm just going to tell you briefly about a story of neuroinflammation by this individual here, Helen Parker, who's way upstream. And this came about because of some work done by Fran Platt, who actually introduced the scientific session earlier, which was looking at the effect of non-steroidal anti-inflammatories in Sandhoff disease mice. And she noticed that actually it increased survival in these animals. It also reduced the amount of inflammation in the brain. And they subtly improved motor coordination. It wasn't a huge effect, but it was enough there to think, well, actually, there might be something in this. There's also a paper by Doug McCarty and Haiyan Fu saying that prednisolone might also be able to change the behavior of MPS IIIB mice. And so we thought, well, okay, we could add this into as a treatment group to one of our therapies in MPS IIIB, which we did. And we gave prednisolone over a fairly long period of time, 6 months, to mice with MPS IIIB. And to our surprise, we found that, well, not that surprising, I suppose, but we found that the peripheral inflammation, the inflammation in the liver, measuring lots of different things, came down quite substantially with prednisolone. You can see it's elevated here in MPS IIIB, all this brown staining, comes down with prednisolone. It's not normal, but it's come down a lot. And the amount of circulating cytokines in the bloodstream has also come down quite a lot too. But weirdly, nothing much changed in the brain, so we didn't see much change in neuroinflammation, and neither did we see a change in cytokines in the brain. However, when we looked at behavior in these animals, it was completely normalized. So we thought, oh gosh, this has got to be a complete fluke. How did this possibly happen? And then we started thinking about it, and we thought, well, actually, maybe there is something in this. Maybe inflammation is important for behavior, because inflammation has actually been shown to be important in behavior in several other neurodegenerative diseases. So what if we target a different aspect of inflammation? And there's a long story that you'll hear about tomorrow, I think. Yeah, from Helen Parker, which I've summarized here, which basically says that if you target interleukin-1, which is sort of major mediator of inflammation in the brain. It's one of the kind of meeting points. It's the focal point of inflammation in the brain, or one of them anyway. And you can target it in two different ways. You can either target a gene product which binds competitively and knocks down the activation of this, or you can knock out the receptor. So we did that first with the stem cell gene therapy approach, and secondly, by crossing MPS IVA mice with lacked the receptor. And in both of those cases, we were able to reduce the amount of inflammation long-term over a 6 to 8 month period. And we were able to correct the behavior completely in those mouse models. So we think that inflammation, or targeting inflammation, it needs to be with very specifically targeted approaches, might be of use as an adjunct in patients. So where to next in the 21st century? Systems of distribution. I think we need to improve on how we're targeting organs. If we're going to target the brain, should we be targeting through an intravenous injection? I don't know. I mean, you know, if it works, great, but is that the most efficient way of doing it? I don't know. Can we target genetically or chemically? Which, of course, we can do, but we should be doing more of it. And I think we also need improved delivery devices. Delivery devices take an absolute age to develop, and they often have to go through their own trial process as well. So brain delivery devices have been a real fundamental problem, I think, in the field. They're improving, but we're still using reservoirs and systems that have been developed in, you know, completely for totally different systems, typically for delivery to brain tumors, for example. I think an enzyme-based product will always have the most effect. These are just my opinion-based pieces here, okay, so you don't have to take this to heart. But, and I think they should be the focus of most effort. So ERT, gene therapy, stem cell-based approaches. I think it's really important that we develop understanding of disease and alternative approaches, because this is a real problem we have in the field. It's very hard to get funding, ever, for pathology. You guys are always extremely excited about treatments, and rightly so. But if we don't understand how these treatments work, then we can't develop new ones very easily. And I think the fundamental reason why this is important is because no therapy is perfect. Most of them are going to shift the phenotype. They might shift it, if we're lucky, by 20 years. They might only shift it by a couple of years. They might change the course of the disease entirely. But it's never going to be completely different. It's going to be a change. It's going to be an improvement, we hope. But you'll notice that most of the improvements in healthcare over the years have all been incremental steps. So I think it's important that we take that on board. And we only have limited funds in this area as well, because there aren't that many of us working in the field. So understanding pathology allows for more targeted approaches, and we can target specific areas more effectively that way. And I think this is important, again, because there'll be many patients at the moment, particularly, who will be ineligible for gene therapy trials, and so we need something for these people too. So what will 21st century medicines look like? And this is the non-sci-fi version, hopefully. I think combinations of a modified ERT approach, targeted adjunct therapies as well, such as substrate reduction, such as anti-inflammatories, more effectively distributed gene therapies, and later gene editing. Not quite there yet, but I think we're getting close. Stem cell-based therapies, replacing missing cells. It's nearly science fiction at the moment, but we're almost there. We really are. So there are actually some really interesting studies coming along at the moment in patients, which are starting to look exciting. And lastly, I think perhaps one of the most important things is making therapies cheaper to deliver and more affordable, because that's a really big problem in the field at the moment, and it will become a bigger problem as time goes on. And one of the issues we have, of course, with making things cheaper is that it's very hard to design sensible clinical outcome measures. I promise this is my last slide. So identifying brain biomarkers is a pet hobby of mine. And one of the problems that we have is that the cerebrospinal fluid, which is this stuff which bathes the brain, this blue, light blue stuff here, is not the brain. It's not the same. It goes around it, but it's not the same. And so data in AAV trials so far do not support a close link between the amount of CSF substrate, the amount of heparan sulfate or the amount of dermatan sulfate in the CSF, and behavioral outcomes. And so we need to think of a way in which we can try and get a better set of biochemical markers. And maybe we also need to think about how we can design better neuropsychological tests as well. They're invaluable, but they're frustrating. They're massively time-consuming for you and for us. And really, we desperately need novel ones, but they take an age to validate as well. And you know, some very smart people in this room have tried to develop tests for these, new tests for these diseases. And it's a real struggle. It's a real challenge. And so with that, I'm just going to leave you with a list of people from my lab and collaborators. Thank you very much.
It's time for our break right now, so you're welcome to take that half-hour break, and we're going to resume back in our family session at 5:30. Thank you.
I am not a stranger to the dark. Hide away, they say, 'cause we don't want your broken parts. I've learned to be ashamed of all my scars. Run away.